So today's topic will be benign prostatic hyperplasia, that is BPH. Benign means non-cancerous, then prostatic means involving the prostate gland, then hyperplasia means the enlarged, it will become enlarged, large in size. Okay, then in the introduction you can see benign prostatic hyperplasia is a benign enlargement of the prostate gland. So non-cancerous enlargement of the prostate gland is known as benign prostatic hyperplasia. In many patients older than 50 years, the prostate gland enlarges, extending upward into the bladder and obstructing the outflow of the urine by encroaching on the vesical orifice. So what will happen? It will occur in people who are above 50 years. Then enlargement of the prostate gland will be occur, resulting in the obstructing the urine flow. And this condition is also known as benign prostatic enlargement, or it is also known as BPH, or the enlargement or the hypertrophy of the prostate. It is most common urologic problem in the male adults. It will occur only in the males. Okay. Then about 50% of all male in their lifetime will develop BPH. Of these men, almost half of them will have bothersome lower urinary tract symptoms. So, definition goes, it is defined as a non-cancerous increase in size of the prostate gland. Non-cancerous increase in the size of the prostate gland will be there, which involves the hyperplasia of prostatic stromal and epithelial cells. The prostatic cells, that is stromal and epithelial cells, will undergo the hyperplasia, that is enlargement, then resulting in the formation of large, fairly discrete nodules in the transitional zone of the prostate. Okay, the transitional zone means the part of the prostate that outflow of urine or the urethra will be there. Okay, it is where the urethra will locate. This will help in what? Obstruction of the urine flow. So these large nodules, which will be present in the transitional zone of prostate, which push on and narrow the urethra, resulting in increase in resistance to flow of urine from the bladder. Okay, so this will narrow the urethra. Okay, the obstruction will narrow the urethra, and it will result in the increased resistance of flow of urine from the bladder. It will not let the urine flow outside the urethra. So this is for the pathophysiology. You can write like first, the non-cancerous increase in size of the prostate gland will be there. Then what will happen? It will involve the hyperplasia of prostatic and stromal epithelial cells, then resulting in the formation of large, fairly discrete nodules in transitional zone of prostate, push on narrow the urethra, then resulting in increased resistance to flow of urine from the bladder. So like this, you can write the pathophysiology in a short form. Incidence: 50% of men having evidence of BPH by the age of 50 years. By the age of 50 years, 50% of men will be having this disease. Then 75 by the age of 80 years. After 80 years also, 75% of the men will be affected. So this is very common among the male. Then causes and risk factors, we can see dihydrotestosterone. So this dihydrotestosterone, it will be this is a hormone which is secreted by the which is secreted in the testes. Then this increased secretion of this hormone will cause the enlargement of the prostate. So this is one of the factors which will help in the enlargement of the prostate gland. Next are the risk factors. Risk factors include the aging. Okay, when there is increase in age, then the symptoms will appear. Then the prostate gland enlargement will be there. Then family history. When having any blood relatives such as father, brother, that means it will increase the chance. Then ethnic background, like prostate enlargement is less common in Asian men. Then diabetes and heart disease. Those who are having diabetes and heart disease will have more chances than lifestyle like obesity will increase the risk of BPH. Next, let's see the clinical manifestations. The first one is hesitancy in starting the urination. Okay, there will be problems in initiation of the urine flow. Then increased frequency of urination. There will be increased frequency of urination. The person will be feeling the urge to urinate more often. Then nocturia, that means more frequent urination during the night time. Then urgency. Then abdominal straining will be there because of the accumulation of urine inside the bladder. There will be pain in the abdomen. Then decrease in volume and force of urinary stream. There will be decrease in the volume of urine and the force of the urinary stream. Then interruption of urinary stream. Okay, the urinary stream will not be coming normally. Then dribbling will be there. Dribbling, that means a stream of urine will not be normal. It will come little. Then sensation of incomplete emptying of the bladder. After the person has voided, okay, if he still feels that the urge to void, that means there is incomplete. Then acute urinary retention, that means more than 60 ml urinary retention will be there. There will be urine inside the retention inside the bladder. Then recurrent UTIs. Then fatigue, anorexia, nausea and vomiting, pelvic discomfort and pain, azotemia we have already known. Then renal failure results with chronic urinary retention and large residual volume. So what will happen? It may lead to renal failure also. Then it will also lead to blood in the urine. Next comes the assessment and diagnostic methods. We'll do the history collection, physical examination, then urinalysis, urine test, then prostatic specific antigen level is obtained if the patient has at least 10-year life expectancy and for whom knowledge of the presence of the prostate cancer would change the management. Then urinary flow rate will be recorded. Then the measurement of post-void residual urine will be done. That means the post-void residual urine, that means the amount of urine which is left in the bladder after urination. Okay, then urodynamic studies like urine. This means to assess how the bladder and urethra are performing the storing and releasing of the urine. It can detect the incontinence, frequent urination. Okay, then urethrocystoscopy. That means examining the urethra with the help of a cystoscope. Then ultrasound will be done to detect any abnormalities inside the bladder and the ureters. Then complete blood studies, including clotting studies. Blood studies, complete blood count can also be done. In the medical management, immediate catheterization if the patient cannot void. If the person is not able to void, then we should do immediate catheterization of the patient. Then a suprapubic cystostomy is sometimes necessary. The suprapubic cystostomy, that means this is also a type of catheterization, but it will be done from the suprapubic region by doing an incision in the suprapubic region. That means above the pubic region they will do one incision. Okay, after that the catheter will be inserted inside the bladder. Then urine will be allowed to flow out of the catheter. So this is one type of catheterization which is not normal, like we do by inserting the catheter from the urethra. Then Alpha blockers will be given to relax the bladder, neck, and muscles and muscle fibers in the prostate, making the urination easier. Then 5 alpha reductase inhibitors. This will help in shrinking the prostate by preventing the hormonal changes that causes the prostate growth. Then next is a combination drug therapy, like the doctor might recommend taking alpha blocker with help along with the 5 alpha reductase inhibitor at the same time if either medication alone isn't effective. Okay, then in the surgical management we can see first one is a minimally invasive therapy. That means there will be no major incision will be there. That means it will be inserted from the through the urethra. The procedure can be done by inserting the instrument or probe through the urethra, but major incision will not be done. Then in the invasive therapy, major surgery will be in the minimally invasive therapy. First one is the Transurethral Microwave thermotherapy, then Transurethral Needle ablation, laser prostatectomy, photovaporization, interstitial laser coagulation, then Intraprostatic Urethral stents. So the first one is Transurethral microwave thermotherapy. What will happen with the help of the microwaves, which are directly delivered to the prostate through the transurethral probe. The transurethral probe will be inserted inside the urethra to reach the prostate. Then microwaves will be delivered through the probe to raise the temperature of the prostate tissue about 103 degrees Fahrenheit or 45 degrees Celsius. So this heat will cause the death of the death of the tissues, okay, abnormal tissues which are developed inside around the prostate, thus relieving the obstruction. Then next is a transurethral needle ablation. So this also uses a needle. A needle will be used to insert inside the prostate to reach the prostate. Then by increasing the temperature of the needle, it will help in increasing the temperature of the prostate tissue causing localized necrosis. That means that it will cause the death of the cells which are present abnormally in the prostate. This also uses low wave radio frequency, okay, to hit the prostate. Next is laser prostatectomy. Laser this includes the use of laser therapy through visual or ultrasound guidance. It is an effective alternative to the first two types. Okay, then the laser beam is delivered transurethral through a fiber instrument, and it is used for cutting, coagulation and vaporization of prostatic tissue. So this will help in cutting the coagulation and vaporization of prostatic tissues with the help of a fiber instrument. The laser beam will be introduced. There are a variety of laser procedures, like using different sources, wavelengths, and deliveries. The next one is photovaporization. Photovaporization uses high power green laser light to vaporize the prostate tissue. So somewhat similar with the laser prostatectomy, this photovaporization will use a high power green laser light to vaporize the prostate tissues. Then interstitial laser coagulation. This is in here. First, the prostate is viewed through the cystoscope. Okay, the cystoscope will be inserted to the prostate. At the tip of the cystoscope, there will be one camera. Okay, this camera will help in the guidance of the cystoscope. Then after that, what will happen? A laser is used quickly to treat precise areas of the enlarged prostate by placement of interstitial light guides directly into the prostate tissue. So here the introduction of laser therapy will be done here through the help of the with the help of the cystoscope. This will help in the this will help in what? Destroying of the prostate tissues. The next is the intraprostatic urethral stents. Here, the obstruction will be relieved with the intraprostatic urethral stents. Okay, the stents are placed directly into the prostatic tissues, and it will help in the relieving of the obstruction in the patients who are poor surgical candidates. But there will be some complications because a stent will be introduced. There will be some complications like pain, infection, and encrustation. Then next is the invasive therapy, that is surgeries. Here the first one is the transurethral resection of the prostate. Transurethral resection of prostate is a surgical procedure involving the removal of prostate using a resectoscope inserted through the urethra. So this instrument called the resectoscope, you can see in the picture, it is inserted through the urethra, and then you will have in the removal of the prostate. The next is the transurethral incision of the prostate. Here in the transurethral incision of the prostate, it is a surgical procedure done under the local anesthesia for men with moderate to severe symptoms. Several small incisions are made in the prostate gland to expand the urethra, which relieves the pressure on the urethra and improves the urine flow. So here what will happen? Incision of the prostate will be done. Several small incisions will be made in the prostate gland so that the urethra can expand and it may relieve the obstruction or pressure on the urethra. Then next is the nursing assessment, like obtaining the history of voiding, including the onset, frequency, nighttime urination, presence of urgency, dysuria, hematuria, etc. All we have to take during the history collection. Then we can perform the rectal examination, abdominal examination. Then perform the simple urodynamic measures. These all diagnostic measures are to be taken. Then here in the patient education and maintenance, we should explain the patient not undergoing treatment, the symptoms of complication of BPH, urinary retention, cystitis. So we have to advise the patient which are not undergoing any treatment to warn them of various complications which might occur, like infections and all. Then advise the patient with BPH to avoid certain drugs that impair the voiding, like cold medication containing the sympathomimetics. Okay, we should advise the BPH patients to avoid certain drugs which may help disturb in the flow of urine flow. Then advise the patient that irritative voiding symptoms not immediately resolve after relief of obstruction. Symptoms diminish over time. So you can read all this health education and health maintenance which we may give to the patients and patients' families. Then next is the complications. So many complications might occur in the patients, including the acute urinary retention. Okay, the patient will be experiencing urinary retention, involuntary bladder contractions. The patient will be having involuntary bladder constriction, then bladder divercula. That means a pouch or sac-like structure will protrude out of the bladder wall. Then cystolithiasis, that means bladder stones. Then vesico-urethral reflux, that means reflux of the urine from bladder to the upper urinary tract. That means from the bladder to the ureter or the urethra. To the ureter. Or then hydroureter, that means the dilation of the ureter. Then hydronephrosis, that means the enlargement or swelling of the kidneys or the ureter due to the accumulation of fluids or urine. Then gross hematuria, that means hematuria will be there. Then urinary tract infections will be there. So these are the main complications which will occur in the patient who is having the benign prostatic hyperplasia. So we have seen that benign prostatic hyperplasia, it is nothing but it is a non-cancerous increase in size of the prostate gland. Okay, then the main causes and risk factors include the aging, family history, ethnic background, diabetes and heart diseases, lifestyle. Okay, then clinical manifestation, we have seen retention of the urine, hesitancy in starting the urine, increased frequency of urination, nocturia, urgency, abdominal straining, dribbling and all. Then in the assessment and diagnostic measures, we can do the urodynamic studies, urinary flow rate recordings, and then the ureterocystoscopy, ultrasound, urine analysis. So this all can be done. Then in the medical management, we have seen the catheterization, suprapubic cystostomy, then alpha blockers, 5-alpha reductase inhibitors. Then in the surgical management, we have seen the minimally invasive therapy and invasive therapy. Under the minimally invasive therapy, there are 6 types. That is a transurethral microwave thermotherapy, transurethral needle ablation, then intraprostatic urethral stents, then interstitial laser coagulation, laser prostatectomy, botobepragation. Then under the invasive therapy, we have seen the transurethral resection of the prostate. So this is the removal of the prostate by inserting the resectoscope. Then in the transurethral incision of the prostate, they will be making the small incisions in the prostate, and this will help in the relieving the pressure in the urethra. In the nursing and assessment, patient education, we have discussed. Then the complications. Okay, this is all about the benign prostatic hyperplasia or BPH.